Thanks a lot for the introduction, and I'm very happy I can talk about quantitative imaging biomarkers here today and how they can potentially be used in the future as a virtual biopsy. Let me first explain what I mean with quantitative image biomarkers, also often said radiomics. So they are describing the image or the tumor, the area of interest, what we are interested in a more comprehensive way, in a more mathematical way that we currently do in the clinic. It can be done on all kinds of imaging. So often CT imaging is used because that's most often used in the clinic, but also MR imaging, PET imaging, all kinds of medical imaging can be used. We need to define a region of interest. And then from this region of interest, what we are interested, we define rather engineered features or deep learning features. Let's start with these engineered features. They can be features of the intensity of the image, so a mean, maximum, a kurtosis of the histogram. It can be texture features describing the change in intensity from one pixel to the next one. Then there are certain kind of transform-based features. For example, the image filtered with a high pass or low pass filter, and then again on this filtered image calculated the texture features. But then also shape features describing the shape of the tumor or the region of interest. So these are engineered features describing the tumor mathematically. And then there are also these so-called deep learning features where we let the algorithm detect the features inside the image, which the algorithm defines as to be relevant. These features are then used for outcome modeling or correlation to clinical parameters, diagnosis of the patient, and ideally adaptation of therapy. I'm working in radiation oncology, so in our case, it would be the adaptation of the radiation dose, but could also be a chemotherapy, for example. Let's define what is an ideal biomarker so that we can see if our imaging biomarker kind of apply for that. An ideal biomarker is non-invasive. It can be done as often as you want. It can capture multiple lesions, but it can also capture one lesion in a very good spatial resolution. There is no inter-observer variability. Of course, it's cheap. And most importantly, it has a high predictive value or a prognostic value at least. Let's start with the intratumor heterogeneity. If we do a tumor biopsy, we can often only capture like a certain point inside the tumor, or we can maybe do a template biopsy, but we are still very limited in the spatial resolution. Additionally, it's a minimal invasive procedure. If we do imaging, we have a much higher spatial resolution. For example, for CT, we can even go to a sub-millimeter resolution, similar for MR scans. On the PET, we still have a millimeter or a 3 millimeter resolution. So we can really capture the tumor heterogeneity, and the methodology is mainly non-invasive. Additionally, with imaging, we can not only capture one lesion, but we can capture the differences between lesions. So we can look into one lesion and see if they, within the same patient, behave similarly. This we have done for a set of melanoma patients, 190 metastatic melanoma patients with at least 2 metastases. And we looked at over 500 lesions, and we did not look how the patient is responding, but how a certain lesion is responding. And we looked at a time point at 3 months in PET and CT imaging, and we did a lesion-specific prognosis if a specific lesion is responding or not. That would help us, for example, in radiation oncology, because we could early radiate this specific lesion, and the patient could stay on his immunotherapy. So intratumor heterogeneity can be captured using imaging biomarkers. So we looked a bit about on invasiveness. We can repetitively do imaging. We can also capture multiple lesions, and the spatial resolution is quite high using imaging. So these are all the some advantages of imaging biomarkers. But let's more look into the prognostic and predictive value, because these are then in the end the most important factors. And for this, I would like to start with cancer diagnosis. For cancer diagnosis, certainly tissue biopsy is the gold standard. And here is a meta-analysis for the differentiation of small lung nodules in malignant versus benign. It includes fine needle biopsy and also core biopsy, and it shows a very high sensitivity of 95% and a high specificity, 99%, to diagnose if it's cancer or not. So this should be the sensitivity and specificity, the performance of the model we should also aim for with imaging parameters. And there was a nice study in Nature Medicine published 2 years ago, which looked at lung cancer screening and the detection of lung cancer in screening CTs, so in low-dose CTs. Deep learning was used in this publication. A deep learning model was trained on over 6,000 CT images, and it was validated in an independent cohort of about 1,000 images. And the performance of this model of an area under the curve of 93%, so was quite similar to what we have seen before in the slide when we looked at biopsy detection of cancer for lung cancer. So the performance is very similar in this specific case, which is of course not the most challenging case, but it's a case where image analysis can certainly help. Then let's look at prognostic biomarkers. So how good is the imaging performing in making a prediction on the survival of the patient? And this is an analysis where they compared the prediction performance of only radiomics to staging to a radiomics nomogram. The word is a bit misleading because this radiomics nomogram is a combination of imaging biomarkers, clinical biomarkers, and also pathology features. And then a nomogram only with clinics and pathology features. So if we look at the performance of only the radiomics model, so only the imaging model, it had a significant performance, but the C-index is rather low with 0.61. Very similar to the staging, it has a similar performance, 0.63. But then if we combine the different parameters in this so-called radiomics nomogram, then we have a significantly better performance. And this slightly outperforms also the clinical pathologic nomogram, where only clinical and pathological parameters are included. So the imaging brings some added value here in making the prognosis for the patient. On the left side, you can then see, based on this nomogram, how the patients were distributed in low-risk and high-risk patients. And we can see that the Kaplan-Meier curves are nicely splitting. So we can define two distinct groups based on this nomogram for survival. But in the end, what would be the goal is to have a predictive biomarker. So prognostic is nice, but even better, we would like to have predictive. And we would like to have something like EGFR for non-small cell lung cancer. We know that if we give gefitinib, which is a targeted therapy, to an unselected cohort of patients, in the end, the patient have a worse outcome in comparison to a placebo. But then if we give it to EGFR mutated patient, we have suddenly a significant better outcome. So EGFR is really a predictive biomarker based on what we can select therapy. And of course, we would like to have something with imaging as well, but it's much more difficult with imaging because we are not on this high biological resolution. We have a resolution of 1 to 2 millimeters, maybe 0.5 millimeter in the best case, but we don't really see biology. We only see an appearance of a tumor. But there are certain studies, they try to correlate the appearance of the tumor with molecular pathways. So there's, for example, this study from Grossman, which they did in non-small cell lung cancer, and they correlated radiomics features to molecular pathways. Then, based on this correlation map, they did a B clustering, and they defined 13 distinct clusters inside this correlation analysis. And these clusters, which show the correlation between the molecular pathway and the radiomics features, they were then correlated to the outcome of the patient and also to clinical characteristics of the patient. And they could show that certain clusters were, for example, looking at the cell cycle regulation. So each cluster was somehow correlated to a certain biology process. Interestingly or nicely, this study was not only developing hypotheses, but it also validated them on a second independent data set. And not only this last step was validated, but each of these steps was validated in independent set. And they could show that radiomics biomarker can really correlate to known predictive markers in non-small cell lung cancer. Another study looked at the response to immunotherapy. So they looked at a data set with mixed primary tumors, and they trained a model in this Moscato data set, which was doing a radiomics signature of the number of CD8 cells. So they defined radiomics parameters, which gives us an idea how strong the cells are infiltrated. This radiomics signature was validated in the Cancer Genome Atlas, and it was validated in a second in-house set. They called it immune phenotype cohort, which was just in a cohort which is very extreme, patients with a strong infiltration and patients with a very small CD8 cell infiltration. Additionally, I like the last step very much. They had an immunotherapy data set. So patients which were treated with PD-1, PD-L1 monotherapy, and they looked if this radiomic signature for CD8 cells was predictive and prognostic in this immunotherapy cohort, so the cohort which was treated with immunotherapy. Let's look at the results. So this is the set they were training on with an AUC around 0.74. Then they validated a slightly worse prognosis, but slightly worse performance, but well within the confidence interval. And then nicely, this signature worked well to split the patients which respond well to immunotherapy and which respond worse to immunotherapy. So this radiomic signature for CD8 cell infiltration was actually predictive for the overall survival of the patients. What is the problem with the imaging biomarkers? We up to now only looked what they can do, but the problem is really that to date, it was not possible that somebody could reproduce any of these imaging radiomics models with an independent software in an independent clinical data set. We very often have it, of course, that the model is validated in independent data set, but it never actually happens that somebody uses another software solution to validate the model. So all the institutes have their own software implementation and they give pretty different output. So validation is a problem currently. We are participating in an initiative led by Dresden to standardize these features, that the output is the same. But up to now in the first round, we standardized about 100 features out of more than 2,000, 3,000 we are currently determining. So it's a very time-consuming process and it will take more time. The other reason for it is that we don't have standardized imaging protocols, and we also don't have a standardized target definition where to calculate the parameter. This we are addressing currently in an SPHN driver project called Imagine. We do a use case for glioblastoma cancer, and we want to standardize in different university hospitals in Switzerland the imaging protocols, the image quality based on regular quality assurance, and also the data curation and the output of the radiomics feature of the imaging biomarkers. And this standardized data should go on a common server, the Biomed IT infrastructure, so that we hopefully then can reproduce models within Switzerland and that we can also do common models together. Of course, it's still in Switzerland, but I think it's a very good first step in standardizing imaging and also image analysis. How should we now introduce such an imaging biomarker into the clinic? And there's the so-called imaging biomarker roadmap published in 2017, which describes actually three steps of introducing an imaging biomarker. And I'm very afraid we are still in this first phase. The first phase is kind of the hypothesis testing, the development of the model, the maybe validation, retrospective validation of these biomarkers. Then we have to cross this first translational gap and we have to get into the phase where we prospectively test these biomarkers. And only after that, we can safely introduce these imaging biomarkers into the routine care, into the routine healthcare system. The work which needs to be done is on a technical side, what I just explained to you, the standardization of the imaging of the output, but also more work is needed on the biological and clinical validation. So I think still we need more and better models. What I didn't talk about until now is the cost effectiveness. Some of these imaging biomarkers are rather cost effective because we use routinely acquired images in the clinic and analyze them for their further values. So they are already done. And also CT, MR imaging is not so expensive. But of course, if we use more advanced PET tracers, it gets more expensive than if we only use standardly acquired imaging. So I think this is a difficult topic. Let me look back a bit into our ideal biomarker. I think it's clear the imaging has a lot of advantages if it comes to non-invasiveness and capturing of heterogeneity of multiple lesions and also how often we can perform it. What we have problems at the moment with is certainly the inter-observer variability. I think pathology is far beyond us. It's a topic for a much longer time. Of course, it exists there as well, but with the imaging biomarkers, we need to better define and still have some work to do in making them observer independent. The prognostic and predictive power, I think I showed you some examples that they can be prognostic, but there's also still some work to do, especially comparing to classical like EGFR biomarkers. So to conclude, how does it compare to tumor biopsy? I think the tumor biopsy has the advantage that the biological resolution is very high, whereas in the image we only see on a millimeter scale. However, we can do much more imaging. Temporal resolution is much higher when we do imaging compared to tumor biopsy. And we have the advantage of imaging multiple lesions at the same time. So why not combine these two and kind of make our perfect biomarker in the end? We've heard in one of the previous talks that it's very difficult to combine different omics data. And I know we need a lot of data for that, but I think it's a good task for the future. And also, I think we should include liquid biopsy, which is in between somehow of the two. It has a better biological resolution, but also a liquid biopsy, we need to take some blood, so it's in between also in the temporal resolution. But I still think in the future, all three together will give us the best biomarker. With this, I would like to thank you for your attention, and I'm happy to take questions. And I would also like to thank my Radiomics team. I took a lot of slides for them. And of course, this work is not possible without the cooperations and the funding. Thanks a lot again for your attention.
Thank you very much for this highly interesting talk. I'm glad as a pathologist, of course, to see pathology on the final slide as one of the components to further develop the methods. So let me see if there are any questions from the audience. So there's one from Mark Rubin. Please, Mark.
So great presentation. Having sat very often with radiology and comparing pathology, one of my, just as a comment, one observation is I think there's just sort of overestimate as to what radiology can do. So I think that sort of limiting expectations might help. That's just a general comment. So a question I have is, in prostate, PSMA, for example, is used as an imaging modality now. And I was just wondering, one of the limitations with that modality is there's a lot of heterogeneity. So you're able to very accurately target the things that light up, but you're missing the other things. And I'm just wondering, is there any strategies to further enhance the expression so that you can overcome this type of heterogeneity? Because I think that's also one of the limitations of this type of approach.
I mean, certainly each imaging modality has its limitation, and in PSMA PET, there are tumors which don't take it, and so you can't see them. But I mean, each imaging has its limitation. I think it's important that we know these limitations in the clinic, and then we can kind of overcome them or tackle them. But currently, in respect to PSMA, I don't think there's a good solution to overcome this.
Okay.
Maybe if I may follow up with another question. So what I'm really interested in is the interpretability of these models, and you outlined the inter-observer variance and also the problems in terms of reproducing the models that have been trained on independent software systems. So I was really wondering about your view on the interpretability of the patterns that are pulled out by the radiologics signatures, and whether that could help in terms of making these actually more reproducible and more robust in terms of translating them onto independent systems.
Yeah, I think this is a very good question, and I think it's also very important. We always try to interpret, so as long as we have the manual features, it's more easy because we can somehow interpret them. So for example, for head and neck cancer, we saw that heterogeneous tumors in contrast-enhanced CT are more aggressive. So we can give some interpretation, and it's always good to look at them with the radiologist, and often they say, yeah, that's something we actually know. But then on the other side, there's deep learning, and I think then it gets even more complicated. But also there we have techniques like attention maps that can show you what is the algorithm focusing on. And I agree we should more use them. And we also have a project now in our group where we kind of look at these attention maps and we want to compare, is it the same? Would it help the clinician to say, okay, this is really, I can trust the algorithm because it focuses on something I would also focus, or it makes sense what the algorithm makes. But I think it's certainly a field of research, and I know a lot of people are starting to look into this direction now.
It's really fascinating.
Indeed. So
we have time for maybe one or two more questions. Let me see. So maybe to follow up on that, the idea of deriving these radiomic signatures in the clinic, of course, requires these to be produced within clinically actionable timeframes. So to go from the detector really to the intervention. Do you think there's a place for edge processing in this, so that really while an image is being, or for example, a lesion is classified for biopsy or detected for a radiologically guided biopsy, a radiomics classifier could already indicate which parts of the lesion to sample? Or do you think that's beyond what would be feasible in the near future?
Actually, it's nothing I thought up to now, but I think it's a very good idea, because I think instead of just putting the biopsy somewhere, I think radiomics could actually give a very good hint on that. And we also have techniques which show locally at the radiomics features. So we can say, okay, this part of the tumor might be more aggressive, and this could actually guide you to biopsy. That's a very interesting idea.
Thank you. So if there are no more questions, I think we will move on in the interest of time. Thank you again for this really interesting topic. And I would like, oh, there's one more question just coming up. Abdullah, please.
Hi, Stephanie, thanks a lot for the great talk. I was just wondering, what attempts are there to combine genomics information actually with the radiomics, and what could be the benefits basically of using, in addition to the, to the imaging that you do, actually, if you would use also genomics information?
Yeah, we have several projects where we try to combine the information. For example, for metastatic melanoma, we try to combine genomics with imaging data. We don't have results yet, for example, on this project, but I think it's certainly promising, but it's also very difficult regarding the analysis, because often we don't have like massive amounts of data. So we try to have like dimensionally reduction methods to look at the important features, but I think it's very promising for the future. Yeah.
Thanks. Thank you very much. With that, I'd like to thank you